we will introduce Professor Reem Abdallah, a consultant of Gynae-Oncology, American University of Beirut. She will discuss updates in the management of borderline ovarian tumor.
Good morning, everyone, and I would like to thank the organizing committee for the invitation. So I'll be talking about updates in borderline ovarian tumor. So as you all know, borderline ovarian tumors present in general with early stage, with an excellent prognosis and survival, even in advanced stages and regardless of histology. Just a new classification, the WHO classification regarding SBOT, micropapillary SBT is no longer considered synonymous with non-invasive low-grade serous carcinoma, and SBT with microinvasion is no longer synonymous with low-grade serous carcinoma. However, for invasive implants, they still consider it as extra-ovarian low-grade serous carcinoma. And I'll come back to this later on in the presentation, because this has created lots of debates among societies. So the overall risk of recurrence in BOT ranges between 5 and 15%, and the median time for recurrence between 4 to 7 years, and even with more recent studies, it's even more than 10 years. However, the more important is the risk of invasive or lethal recurrences, which range between 0.5 and 4%. And if you look here at the prospectively collected cohorts of more than 200 patients, and this includes more recent and large studies, you can see that the overall risk of recurrence is about 14%, and the risk of invasive recurrence is about 2%. Now, invasive implants have long been considered the most important prognostic factor for borderline ovarian tumor. And in a meta-analysis in 2016, they looked at the factors that were associated with lethal recurrence. And they found that microinvasion alone did not significantly increase the risk of lethal recurrence, whereas micropapillary architecture and the presence of implants, any implants, significantly increased the risk of lethal recurrence. And the risk was the highest for invasive implants, as you can see, which almost double or even more than double. Now, regarding mucinous subtype, intraepithelial carcinoma is still a controversial prognostic factor. However, in this pooled analysis, neither microinvasion nor intraepithelial carcinoma were associated with increased risk of lethal recurrence. And it should be noted that mucinous borderline ovarian tumors are almost always stage 1. So the finding of an advanced stage mucinous borderline ovarian tumor should really be questioned, as this is most likely from a GI invasive carcinoma in general. So the relapse in mucinous borderline ovarian tumor is in general less frequent than serous subtype. However, according to previous meta-analyses, whenever recurrence occurs in mucinous subtype, it's usually associated with higher risk of invasive or lethal recurrence, in particular when cystectomy is done, and the time to progression is shorter, and there are more extra-abdominal sites of invasive recurrence. Now, the issue of implants cannot be discussed independently of stage, and in the previous meta-analyses and studies, they lumped all the stages together. So if we look in particular on patients with implants, where the risk of invasive recurrence is higher in patients who had initially invasive implants as compared to non-invasive implants. And the risk of death is substantially higher, 30% as compared to 6%. A more recent and large study by the French group in 2020 looked at 212 patients with stage 2 and 3 with peritoneal implants with a long median follow-up of 115 months. And here they found out that invasive implants was significantly associated with higher risk of invasive recurrence, which was consistent with previous studies. However, this did not have any impact whatsoever on disease-free survival or overall survival. And in fact, when they include more patients and the follow-up was extended, which was even more than 10 years, this led to the disappearing effect of the prognostic value of the type of implant. on the lethality. And as you can see here that patients with invasive implants, the recurrences, the lethal recurrences and the death occurred earlier during the time course, whereas in non-invasive implants, it occurred later. So when you extend the follow-up, the significant prognosis of the type of implant is lost. And in this study in particular, 30% of the patients recurred after 5 years of the initial treatment. So this highlights the importance of having a very long follow-up in these patients, regardless of the type of implant. So now if we include the previous studies and we add more recent and large studies by Vang, De La Marquette, Maurice, Platt, Gia, and Falcone, here you can still see that the risk of invasive recurrence is higher in patients with invasive implants. However, the risk of death seems to be a bit less. And if you look at the numbers, most of the deaths occurred in old studies. And the highest risk was in patients who had initially invasive implants. So maybe in these old studies, there were a number of patients who were labeled as borderline ovarian tumor with invasive implants, but who were truly having low-grade invasive carcinoma and not BOT. The other issue is that serous borderline tumor with invasive implant, as we said, is now classified as low-grade serous carcinoma. However, this has been debated by societies, in particular the ESMO and the ESGO. And this is because the clinical behavior might be different. So most of the patients in advanced stage low-grade serous carcinoma are going to recur, whereas the risk of invasive recurrence in SBOT with invasive implants is about 30%. And in addition, the distinction between invasive and non-invasive implants could be subjective, and we don't know exactly what's the impact on prognosis of the extent of invasive implants. And the treatment approach in young patients regarding fertility-sparing surgery and adjuvant treatment is different. So this led the ESGO and the ESMO in their consensus in 2023 to consider SBOT with invasive implants as separate from advanced low-grade serous carcinoma. Moreover, if you give chemotherapy to these patients with invasive implants, this did not decrease the risk of recurrence and did not have any impact on mortality or survival. And thus, the ESGO and ESMO recommend against the use of adjuvant systemic therapy for the primary treatment of SBOT with extra ovarian implants, regardless of the type of implant. However, the ESGO mentions that for patients with invasive implants, chemotherapy may be considered. The NCCN still considered BOT with invasive implants as equivalent to low-grade serous carcinoma, and thus they are treated similarly. Now, about a third of the patients with BOT present usually before the age of 40, so in their productive age, and thus fertility sparing is very important. We know that the risk of recurrence in fertility sparing surgery is higher than radical surgery, 10 to 20% as compared to 5%. However, more importantly, the risk of invasive recurrence was not increased, so it's the same. In an old meta-analysis in 2015, they looked at patients who had fertility-sparing surgery, and they found that for patients with unilateral tumors, whenever you do cystectomy as compared to unilateral salpingo-oophorectomy, the risk of recurrence was much higher in patients with cystectomy with an odds ratio of 2. And this was true for both serous borderline and mucinous subtype. However, the risk was higher, much higher in patients with mucinous borderline ovarian tumor with an odds ratio of 4.5. Now, regarding bilateral tumors, whether you do bilateral cystectomy or you do unilateral salpingo-oophorectomy with contralateral cystectomy, there was no difference in the risk of recurrence. And again, more importantly, the risk of invasive recurrence as invasive cancer, is about 2%, which is low. And also the survival is excellent with very low mortality, and the reproductive outcomes were also excellent. Now, the largest study to date that addressed fertility-sparing surgery was conducted by De La Marquette in 2019 with more than 500 patients who had fertility-sparing surgery with a median follow-up of 12.4 years. And here, the overall risk of recurrence was 35%, And at 10 years for unilateral tumors, there was no difference in the recurrence rate for USO versus cystectomy. The risk of recurrence was higher for bilateral tumors, but still, the difference did not reach statistical significance between doing USO with contralateral cystectomy and bilateral cystectomy. And the numbers are even higher for stage 3 and stage 4 disease, but the risk of recurrence as invasive cancer was still low, less than 2%. And it should be noted that the risk of relapse did not really decrease with time, even after 10 years. So this highlights the importance of long-term follow-up in these patients. Moreover, if you do unilateral salpingo-oophorectomy, so a more radical approach in unilateral tumors, this did not protect the patients from contralateral relapses. And thus, if you have a unilateral tumor, probably we should do our best to do cystectomy in these cases, according to this study, because having contralateral relapse can be deleterious to fertility, especially when the patient has already removed the other ovary. The other important thing is in this study is that there was no difference according to histologic subtype. So even in mucinous histology, there was no difference in this study between cystectomy and salpingo-oophorectomy. The survival is excellent, low mortality, reproductive outcomes are also excellent, and the factors that affected fertility the most is the number of interventions. So when you increase with any additional intervention, there is a decreased chance of fertility. So this is the ESMO guideline from 2019. They recommended unilateral salpingo-oophorectomy for mucinous borderline ovarian tumor, and cystectomy is acceptable for serous borderline. Now, the most updated guidelines are the French guidelines. So they recommend that in early stage bilateral serous borderline tumor and fertility desire, bilateral cystectomy as much as possible is recommended. For mucinous borderline and fertility desire, unilateral adnexectomy is recommended. And if a patient has early mucinous borderline and she already was treated with cystectomy, reoperation for unilateral adnexectomy is recommended regardless of fertility desire, whereas for patients who were treated with cystectomy for serous borderline and they have a fertility desire, reoperation for adnexectomy is not recommended in the absence of suspicious residual disease. So fertility-sparing surgery in early stage increased the risk of recurrence, but was mostly non-invasive, and it was mostly on the ovary, whether ipsilateral or contralateral, and thus it's easily cured by surgery with no impact on survival. However, can we propose this regardless of disease stage? Well, if you look at studies for fertility-sparing surgery in advanced stage, a meta-analysis on a small number of patients with a small number of studies confirmed that there was an overall risk of much higher risk of recurrence when you do fertility-sparing surgery for these patients with an odds ratio of 5.5, with no impact on 5-year survival nor 7-year survival, and this is regardless of the histology. So the ESMO 2019 recommended that fertility-sparing surgery could be considered in selected patients with stage 2 or 3. However, all peritoneal implants must be removed. Now, two more recent studies, one by the French group, the other by the Italian group, were recently reported regarding patients with implants. The Italian study reported on 91 patients who had fertility-sparing surgery. They had stage 2 to 3 serous borderline tumor, and 13 patients had invasive implants. The median follow-up was long, 127 months, and 54% of the patients had a relapse. The risk of relapse was significantly higher in patients with invasive implants. The time to first relapse was 22 months and was shorter for patients with invasive implants, but did not reach statistical significance. And more importantly, all the patients were salvaged with surgery, and the surgery was still conservative in 2/3 of the patients. Another 16 patients had a second relapse, and 5 patients had a third relapse, and almost the vast majority still were salvaged with surgery, and more than 2/3 still had repeat conservative surgeries. The risk of recurrence as frankly invasive carcinoma was 2%, and in this study, the type of implant significantly predicted the risk of recurrence. It was an independent predictor of recurrence. Again, with a long follow-up, in this series, only one death occurred, and this was in a patient who had stage 2 and non-invasive implants. And here you can see the disease-specific survival, which was very high. Reproductive outcomes were also excellent, and there was no cases of recurrence after ovarian stimulation or IVF. The second study is the French study, which reported on 65 patients who had fertility-sparing surgery with serous borderline tumor and peritoneal implants. 8 patients had invasive implants. The median follow-up was 6 years. Again, the risk of recurrence was similar to the previous study, 58%. However, more patients had recurrence as invasive carcinoma in this study. And this could be due to the fact that there were more patients with stage 3 in this study, more patients had incomplete cytoreduction, more bilateral tumor, and less patients had adjuvant treatment. However, the survival was not different in terms of overall survival between conservative and radical procedures. And there were 3 deaths in this study. And the type of implant did not have any impact whatsoever, neither on disease-free survival nor on overall survival. What about fertility-sparing surgery in invasive implants? So, as mentioned in the previous studies, according to the Italian study, the invasive implants increased the risk of overall recurrence, but did not have any impact on reproductive outcomes or overall survival. In the French study, the type of implant did not have any impact on any of these outcomes. So if we look at the Italian study with 13 patients with invasive implants, 11 patients recurred, and all of these 11 had surgery, and 2/3 had fertility-sparing surgery still. All the recurrences were invasive, but there was no frank cancer. And 5 patients had recurrences outside of the ovary. So this maybe gives us an idea that maybe the risk of recurrence is not truly related to the ovarian preservation per se, but rather to the natural history related to the extent of the initial peritoneal disease. Again, there were no deaths in the study, and at the end of the follow-up, all patients were alive with NED, with no evidence of disease. So if we summarize the literature for patients with advanced stage SBOT with invasive implants, with fertility-sparing surgery, the risk of relapse is very high, 75%, malignant relapse 7%. However, there was 1 death among 30 patients, which is very important. So the French guidelines recommend that in advanced stage, fertility-sparing surgery can be considered in patients desiring fertility, regardless of the type of implants, after discussion at the tumor board, and the aim should be for R0. The NCCN says that fertility-sparing surgery is an option if fertility is desired. The aim should be R0, and completion surgery after completion of childbearing is recommended in the NCCN guidelines, but not in other guidelines. So here's a summary of the recurrences and survival in patients with implants, any type of implants who had fertility-sparing surgery. Overall risk of recurrence, 50%. Risk of invasive recurrence, about 14%. However, the risk of death from disease is low, 2.4%. And thus, the recommended management nowadays is exploration of the abdominal pelvic cavity, BSO for patients with no fertility desire, and fertility sparing if the patient had fertility desire. If you have mucinous tumor, still unilateral salpingo-oophorectomy is recommended by guidelines. Bilateral cystectomy should be done if you have bilateral disease. If you have endometrioid subtype, hysterectomy is recommended, and if fertility is desired, at least endometrial sampling. Peritoneal staging surgery with cytology, biopsies, omentectomy, or omental biopsy. Appendectomy should only be done if the appendix looks grossly abnormal, even in mucinous subtype, and the aim should be for complete removal of all macroscopic tumor. Now, restaging is recommended if you have a serous borderline tumor with macropapillary component and inadequate exploration of the abdominal cavity. If you have a mucinous borderline ovarian tumor and cystectomy was only done, and if you have a mucinous borderline tumor and appendix was not visualized. And fertility-sparing surgery should be considered in serous borderline tumor, even with invasive implants. And repeat fertility-sparing surgery even may be considered in the absence of malignant transformation. And a long follow-up is recommended for all these patients, regardless of the type of implants. And thank you.